So we're grateful to have Dr. Hani from Brunei, who will be speaking on oral health and hygiene in special care patients. So Hani, welcome. And on the panel, we have Dr. Jacob John from the University of Malaysia and Professor Callum Durward from Cambodia, Phnom Penh. So Hani, thank you for so much for giving up your time, and we look forward to your lecture.
Thank you very much, Prof. As I said, thank you so much for it's a pleasure for me to be here, and it's an honor to present this this lecture on oral health and hygiene care for people with disabilities. As you know, this lecture is part of the lecture series brought by the Global Child Dental Fund. In this lecture, we'll cover about what disability is, oral health with and people with disabilities, as well as hygiene care for people with disabilities, where we will learn how to develop an oral care plan to support people with disabilities. So, first of all, disability is part of being human. Everyone is likely to experience some difficulties in functioning in some point of their lives, particularly when they're growing older. It can affect all ages and social classes, and approximately 40% of global population experience disability, and they include 12% of those aged 18 to 64, and about nearly 40% of those above 65 years old. The United Nations Convention of Rights on People with Disabilities defines people with disability as those who have a long-term physical, mental, intellectual, or sensory impairments that could, with which in interaction with various barriers may hinder their full and active participation in society on an equal basis with others. An impairment refers to a functional limitation of a person's ability. And this could mean caring for oneself, walking, hearing, seeing, breathing, reading, or any of our day-to-day activities. Another way of understanding disability is through the World Health Organization International Classification of Functioning, where the outcome of the interaction between individuals with a health condition and the personal environment and the environmental factors. So it covers not just impairments, but also activity limitations and also participation restrictions. So hence, not all people with impairments would have a disability, or would they require special, or if they require special additional needs. This is the same with dental care. As we go through in this, people with physical disabilities are those where it affects their mobility, their physical capacity, stamina, or dexterity. Having a physical disability does not necessarily impact on a person's health status. However, restrictions in hand mobility may impact the access to the mouth in terms of oral care, or their physical ability may impact their access to dental surgery if they didn't have any accessible parking or accessible dental surgery itself. For people with intellectual disability, those are those with impairments that affect how someone learns, how they communicate and carry out everyday activity. The amount of support that they require throughout their life varies according to their intellectual disability, and they may have any additional disability. However, their difficulty in communication can complicate relaying if they are in pain, or to describe the source of pain. Sometimes the untreated pain that they experience can present as a challenging behavior. People who experience impairment of any of the 5 senses are people with sensory disability. For example, for people with visual impairment may affect their ability to see. So they would find it difficult to see whether they've done the oral care effectively. People with hearing impairments may find it difficult to listen to instructions, or people with speech difficulties may find it difficult to communicate and require other means of communication. With regards to touch, it's important to include people with autism spectrum disorder. This is a developmental disorder where individuals find it difficult in processing of everyday sensory information. Further support may be required as they have differences in their communication, and they may have restrictive behavior, which make it challenging in any changes to their everyday routine. People with psychological disability are those who have long-term mental disorder or illness, and this may cause dysfunction in their day-to-day lives, impacting their social life and also work life. It is important to note that an individual may have more than one disability or may need more support in overcoming this. Next section would be our people with disability and oral health. When compared to the general population or people without disabilities, people with disabilities have more access to oral care, and they have higher levels of oral disease. Studies have shown that people with a disability have poorer oral hygiene, higher pulp levels. They have more extensive and severe periodontal destruction, as well as higher rates of untreated caries. This is due to the poor access to oral care, and hence they have more severe oral disease. With care being provided late, higher rates of teeth are resulted in being extracted, and with fewer replacements of teeth. The oral disease people with disabilities experience remains untreated, and this places additional burden to their quality of life when compared to those of without disability. The risk of oral disease increases when the person has more than one disability or complex health issues. And we know from studies that oral care for people with disabilities are not complex, and they can be provided by experienced dental practitioners in primary care settings or community settings where patients can have a dental home, where it's a facility, a dental care facility, which is local and familiar to them, which they can go to for dental checkups and treatment. Complexities. The British Dental Association developed a case mix toolkit to assess patients' complexity in receiving dental care. And this can be applied for patients with disability or patients requiring special care needs. Assessment is done according to 6 identifiable criteria. First of all, their communication. It reflects on the issues of communication between the dental team and the patient, their guardian, or even the carers when they're in the surgery. Patients may have non-verbal communication or use of assistive devices. Secondly is patient's ability to cooperate, or it affects the delivery of dental care. Patients' ability to open their mouth to accept care, or when they require behavioral techniques such as distraction, desensitization, or need for additional staff to support care for them. Patient's medical status, their complex medical history may require modification to care, for example, for patients with stroke or neurodegenerative disease. Patients may have oral risk factors that could complicate care, such as malocclusion, xerostomia, sensitive gag reflex, dysphagia, patients who are peg-fed or with severe erosion. Access to oral care refers to how a patient attends from their home to the dental surgery and how treatment and then to the dental chair. Do they need any special transport, any special equipment, or if they're required to be seen outside of the dental surgery by use of mobile clinics or domiciliary dental care. And the sixth criteria would be any legal or ethical barriers, such as regarding consent to dental care and and receiving dental treatment. So in this section, we look into oral hygiene care for people with disabilities. So what sort of support or how the development of an oral health care plan to help support their care on a day-to-day oral care. So with reference to the evidence-based documentation on delivering better oral health, the principles of oral care also applies to those who require special care needs or people with disabilities. In that brushing teeth twice a day, to have it twice a day, lasting at night or one other occasion, using fluoridated toothpaste, spitting out after brushing rather than rinsing, and then also to minimize the amount and frequency of sugar food and drinks in terms of diet. Studies have shown that oral care for people with disabilities are quite complex. They require adaptations and modifications to conventional treatment planning. And this needs to be within the needs and preferences to the individual patient and also their carers. And as well as the incorporation of preventive dentistry. Individualized oral healthcare plan should be developed through identifying the problem of the issues that we want to address, what the goal is, needs to be realistic, and provide ways on how this can be approached. So problem could be what their daily oral hygiene can be complicated by their behavioral or medical status or habits, or that patients may have halitosis, or that they have high caries risk, or hyperiodontal disease, dry mouth, dietary consistency, or any other problems that they needs to be addressed. Looking at this problem, we look into what goals we want to do, and it could be very simple. Simple goals, improving oral health, or either that or reduction in the physical resistance, increase incorporation in daily brushing, or to maintain or achieve any ability to perform their own oral care. The goal could actually be in the next 6 months, no new caries. And we're looking at approaches, the 4 approaches that we can look into for the individualized oral health care plan. First of all, we look into the individual considerations. First, to check how much support does the patient need in performing oral care. Can they brush without any assistance? Can they effectively brush with supervision, with reminders, prompting, or timing? Does the patient have some dexterity, but their cleaning techniques may be insufficient? So we may need some hand-over-hand techniques or prompting, or completion to let them start first and then complete by the carer. Or there would be some patients who require significant or total assistance in oral care. Next one will be toothpaste use. Can they or can they not use any toothpaste? If they do, what sort of toothpaste do they have, whether they need control, desensitizing, or whether the toothpaste needs to be flavored or non-flavored, low foam, especially for those with dysphagia. And if they cannot tolerate any toothpaste, perhaps dry brushing or having a moist toothbrush, whether the toothbrush is dampened with mouthwash. Can the patient rinse? And if they can, perhaps to incorporate fluoridated mouth rinses for them. Patient's ability to floss. We're looking at also toothbrush choices. There's no superiority in toothbrush or toothbrush choice. It could be soft bristles, whether it's powered, it's angled, whether use of suction brushes, or aids to help with the toothbrushing. And then lastly, what method of brushing do we need to use? Whether it's horizontal brushing, circular, gentle vibration, whether it's a quadrant by quadrant. So this is just an example of toothbrush choices that can be used with the Collis curved brushes or the Barman's toothbrush. Any modifications in the holder to help with patients with holding the toothbrush themselves. The second approach is in terms of positioning, whether we're looking at how the patient or the individual is positioned, whether they're seated either in a wheelchair or in the kitchen chair, lounge chair, bathing chair, doesn't mean whether it's preferred, sitting is preferred, or whether standing would be preferred. And if the patient is lying down, whether the torso needs to be supported or to the side. Secondly, would be provider positioning for those providing the brushing. The two most common positions would be to the side and towards the back. Other factors to look at would be if there's any lip and cheek retraction to allow visual access, and other needs to ensure safety. For example, an additional person to help support the brushing. You can check out the website www.brushmyteeth.ie that has a number of videos on toothbrushing for whether for different positions, whether they need whether dependent, independent, or some help, and the different types of brushes that they have. The third would be any behavioral support. So this could mean a number of things. For example, a scheduled time. You're looking into whether brushing would be done in the morning or what time exactly, and how many times the brushing would be, whether it's 2 times a day or 2 times per day, and how many minutes is required for proper brushing and support to allow effective brushing. Whether rest periods need to be allowed. You can have egg timers or alarms to make sure it's within the scheduled limit. Secondly, you're looking into the place or the location, mostly the room and location, to ensure comfort for both the individual and also for the carer. To ensure enough lighting and accessible positioning for the carer if the individual require care. Thirdly, for use of instructions and explanation, whether it could be verbal or pictorial or use of videos to show that it will be, brushing time. to include the patient in the or the individual in toothbrushing time. For example, where's your toothbrush? Let's go brush your teeth now. That could their inclusion may increase their cooperation in the extent of their abilities, depending on the extent of their abilities. The environment, whether you want to include or exclude any distractors. For example, use of music, TV. Reinforcers would mean any promised activity for after brushing, any praise as well. So this should be included in positive reinforcement plans on how, like compliments, praise, stickers to build their self-esteem and even increase their coping skills. For those who requires full support or in their providing for those who require supervision or provide support for oral care, especially for individuals who resist oral care, they may need a support plan. And for example, in mouth opening for using another toothbrush or mouth props to help to help aid oral care in the training, for example, and also to build their confidence. Lastly is on oral touch and desensitizing. So this could be separate from the brushing itself. It's to allow the individual to accept care, either to just put a glove finger or washcloth, just so that they are used to having being touched on around the oral area. Lastly, for any special adjuncts, if they have been prescribed any oral treatment, such as high concentration fluoride toothpaste, whether they need use of correxin gel, fluoride rinses, needs to be incorporated into it. Whether flossing can be done on their own or needs to be assisted. Edentulous patients who has a removable prosthesis may require additional care or additional instructions on denture hygiene care. And then lastly, just an assessment of the intake of and frequency and the consistency of food for any sugar intake. So in conclusion, all individuals have a right to equal standards of health and care, including oral health. Good oral health has positive benefits for health, dignity, self-esteem, and as well as social integration. The impact of poor oral health can be profound, especially in people with disabilities. And there is no one-size-fits-all approach in providing oral care for people with disabilities or special care needs. Instead, individualized adaptations to evidence-based recommendations is key to the success in improving oral health. These are some list of useful resources that you can look into to get more information for people with disabilities. Thank you.
Dr. Hani, thank you so much. What an excellent lecture. And thank you for sort of opening up quite a number of really interesting insights into the oral hygiene. I'm just going to open up the question time to Dr. Johns. Jacob, do you want to ask any comments, questions?
Thank you, Dr. Hani, and it was very. You have put them all in the perspective of how to what to look out for, as well as how to manage those with physical, psychological, intellectual, or sensory disabilities. Now when you also mentioned about the approaches, right? The four aspects of approaches. They all come in different levels. So is there any specific guide as to how you will be able to categorize them into a specific need, or we have to look at them individually, those approaches?
I think we're looking at we're looking into different studies basically for people with disabilities, and we know the approaches that they have. We sort of know these are the four approaches in terms of individual, physical, behavioral support, and special adjuncts. And this can be different for everyone. Everyone is different. Whether someone says they have the same one condition does not mean that they have the same condition. So it should be catered to what they have. With this individualized adaptations, as I said, it would encourage them to be much more engaging to their own oral care. So it could be, and we can start with simple things, little things. We start with what they have in place at the moment first. To change it drastically would be too big of a change. So start simple, small behavioral changes first, and then we can tweak it as we go along. Yeah. Is that what you, yeah,
that's really helpful. Thank you. Callum, I'm not sure whether we've lost you. Are there any comments, questions on your part?
Can you hear me?
Yeah, we can.
Okay. Yes, sorry about that. I had to leave, but I've been listening to the presentation. Thank you very much, Dr. Hani. One comment I have is that for many people with disabilities, they or their families often do not prioritize oral health. What do you think some of the reasons for that are?
I think oral health has always been the backseat of everything, like of general health. It's trying to incorporate oral health into the general health. I think a lot of, I suppose if we want to be real, oral health, oral care can be challenging. It's being close to them, close to the individual itself. So it can be a challenge, but knowing that the impact on how if we neglect oral care, or if we find the, how do I say it? If we feel that oral care is not important, no, that's not right, hang on. I would say we have to put oral care back into general health, because it's all about communicating. It's all about their ability. We have to stress on the importance of how oral health would affect how they eat, how they speak, how they smile, and how they engage socially with those around them. And I think, as I said, there's studies that says that oral care is hard to do, and not hard to do. It's if you haven't done it, it can be quite challenging. But it's the small steps that you need to learn how to do it in small. You need to break down the steps into more manageable tasks to help make it a little bit easier.
Good. That's really helpful. Thank you. Dr. Hani, one of the often questions that I'm asked is the role of high fluoride toothpaste in many of these patient groups. Do you have any thoughts or any guidelines that you use when you recommend, say, a Durward toothpaste of 2,500 parts per million or 5,000 parts per million?
Most of the time, it depends on the availability of the toothpaste itself. You're looking into you would need to look into their caries risk assessment. You're having a look at how much caries do they have over the past 6 months or the past year, or what sort of who they are. We're looking into the evidence based on the delivering better oral health, as I said. But it's also down to whether it's available to where you are. I
Sure.
mean, most of the patients with special care needs would require higher fluoridated toothpaste at 5,000 parts per million. But depending on whether they can rinse out, whether do they have fluoridated water as well. So those does play a role in choosing which concentration you want to go for.
Okay, I can understand that. No, that's really helpful. Well, I just want to say it has been an excellent time. You've given us a lot of food for thoughts, a really good structure about thinking about oral health and hygiene in these special care groups. So thank you very much for that. And we wish you well in Brunei. Okay, thank you.